invite you also. Thanks, Fola. I would like to invite you also to put your information. You can introduce yourself in the chat, say where you're from, what your role is, that kind of thing. And like I say, we'll be also looking for questions and comments in the chat. I'd love to turn it now over to Pat and Erin. I'll let you introduce yourselves. Thank you.
Thank you so much for having us. Excited to be here and to talk about wound care, skin and wound care. I think there's like a huge wealth of knowledge in this group, so I'm excited to have some conversation. I think to get started, a little bit about us. So Pat thought this picture would be cute to include. It is my graduation photo from nursing school, so that's me about 10 years younger. Actually, before I was in nursing school, I worked supporting the education program with Wounds Canada, and which I guess was like total nepotism because I was new in the city of Toronto and needed a job and was struggling. So I got this little research assistant position and then started working with Wounds Canada. So it was actually wound care nurses who sort of inspired me to get into nursing, including my mother and my Aunt Pat, who are also in this photo. So I graduated in 2013, and I first started working at Casey House, which I know is a place where a lot of other folks who've gotten into harm reduction started their practice. And then in 2017, I volunteered with the Moss Park OPS when it was an unsanctioned site in the park. And that's sort of where I don't know. I mean, harm reduction is pretty transformative, I think. And it was a significant experience for me. So when I had the opportunity to move into a full-time position with the sanctioned Moss Park site, which is administered by South Riverdale Community Health Center, I made that move and I've been there ever since. And do a lot of really interesting wound care. And work with a really amazing community. Pat has often been a source of consultation for me. Really happy to be presenting with her today. Pat is, I don't know if she'll say this about herself, but she's an internationally recognized educator in wound care and has certainly taught me a lot. So Pat, I'll hand it over to you for more introduction of yourself.
Thank you, Erin. I need to tell you a very cute story about this picture. Erin was showing it to one of her friends, and obviously I am the one in the black and white photo, and her friend asked Erin if that was her grandmother. No, I'm her aunt, as she's already told you. But I have been a nurse for a significant number of years. As you can see the difference in the photo and what you're seeing now. I've actually worked in the field of wound care for about 35 years. I am now semi-retired. I've moved from Mississauga to London, and I have a real passion for caring for people who have wounds. And I have been fortunate enough through my career to be able to do a lot of teaching and learning from people who have wounds by listening to them. And I would really appreciate any input and any questions that you have today, because we all learn as we're coming from the different aspects. I have been fortunate enough to do some international travel. I have managed to do all of the continents except Asia, and have had some life-altering experiences being in Uganda and Guyana, and realizing just how fortunate we are here. So just so we don't take up more time, because we have a fairly full slate, Erin, do you want to start the presentation?
Absolutely. So our objectives for today are to recognize basic principles of wound care, define chronic versus acute wounds. I think in my practice, the majority of wounds that I see are acute, and the really interesting ones are the chronic wounds. And identify the implications of documentation, discuss 2 interactive case studies from my practice. We're going to talk about dressing selection and local wound care, as well as antimicrobial therapy. Explore some tools and resources, reflect on the implications for people who use drugs and people who are homeless and underhoused, and most importantly, have a discussion. Really want to hear what you're seeing and what's been challenging and or effective in your practice.
So there are some relatively basic principles that we follow. And the first one is the client-centered concerns, and really looking at what's the difference between adherence and compliance. And in my world, we really are adverse to the term compliance, because compliance actually means to follow an order, where adherence really talks about being part of that goal of care, whatever. You comply to a speed limit, or how many of us do comply to a speed limit that's on the roads? Even if we are 1 or 2 kilometers over that speed limit, we may not comply with it. But we would adhere to something that is going to be beneficial to all. So being very aware of the language that we use is really, really important. Coherence is even a better term, because that means that everyone is buying into whatever that particular plan is. And if you're across the pond, as they say in Europe, concordance is the term that's used. But again, really trying to avoid that word compliance, and it slips up, especially amongst the medical community a lot. We see it, and I don't think we really know what we're implying when we're doing that. Treating the cause of a chronic wound is so very important. If you don't know what the cause of that chronic wound is, you're not going to be able to kind of help and help that wound to heal. And one of the things that we need to remember is that the wound is on a person, and the person is in an environment, and their environment is within a system. So you need to take all of those 4 components into consideration when you're treating anybody, because if the system won't allow you or permit you or enable you to give the person the best care, then you're not going to be helping to get that wound closed. And then the other thing to consider is the local wound care. So how do you cleanse that wound? How do you debride that wound to get rid of the dead tissue that's there, and keeping the bacteria in the wound within balance? And controlling the moisture is the other important thing. And you'll see in a graph that we have, or a chart that we have a little later on, that there is a wound bed preparation paradigm. You're not the only one having trouble with words this morning, Rachel. That when we're treating chronic wounds, we follow very closely, and it helps to make sure that you're looking at all avenues. Next slide, Erin.
Mm-hmm.
So just as a brief review, all wounds go through these 4 phases of healing. The immediate response is the hemostasis, so the bleeding stops. The inflammation lasts up to 4 days. The proliferation phase of the growth of new tissue takes anywhere from 4 to 21 days. And then the maturation phase is up to 2 years. So we have to keep in mind that anyone with a chronic wound, their wound is not healed until they have reached that 2-year phase, when all of the collagen has aligned itself as it should. So we very often refer to chronic wounds as closed wounds as opposed to healed wounds. So keeping those 4 steps in mind is very important. Move on to the next. And this is, Erin thought I was nuts when I sent her this slide. Would you agree, Erin?
Yeah, thought it was a lot.
Yeah. So there's a course called the International Interdisciplinary Wound Care course that's run out of the University of Toronto. And one of the articles that was in that course was a very scientific article on how wounds heal. Yvette, who did this diagram, her husband is an electrical engineer, and she took his electrical engineering program and put all of the stuff that needs to happen when a wound heals into the program, and this is what it came up with. So you can see that it takes it from the time of injury through to the time of remodeling. If any of these steps, Erin, I don't know whether the arrows will come in or not if you push again. If any of these steps are interrupted, we go back. And that's what happens in a chronic wound. I don't, nobody expects you to remember this. It's just, in my mind, I'm a very visual learner, and this helps me to realize just how intricate the body is and what a wonderful job it does. So just remember that if anything interrupts those phases, you'll kick it back into that inflammatory phase, and then you need to get it back out of there. Okay. Next slide, Erin. So just again, as a review, an acute wound is a wound that occurs when the integrity of any tissue is compromised. So blisters, muscle tears, burns. And the wound may be caused by an act such as a gunshot, a fall, surgical procedure, or infectious disease. These wounds heal by primary or secondary intention. Whereas a chronic wound, which is the next slide, Erin, is a wound that fails to progress through an orderly and timed sequence of a repair, or the wound passes through the repair process without restoring the anatomical or functional results. So that anything that is present for longer than 6 weeks is considered to be a chronic wound. In actual fact, if it's longer than 4 weeks, it's considered to be a chronic wound because it hasn't gone through how it should. What we also have been doing in the chronic wound care field is look at whether the wound is healable. And that's a wound that has enough blood supply and tissue perfusion, and you can correct or optimize any coexisting factors to encourage that wound to heal. And unfortunately, in our world, a lot of people think the dressings will heal wounds. And if you don't correct or optimize those causative factors, you're not going to get that wound to heal. Next slide, Erin. There's a maintenance wound, and this is a wound where it could heal, but because of patient-related issues or system factors, these wounds will not heal. So if something isn't available that someone needs, in particularly a person with diabetes, if they can't get and have a wound on their foot, if they can't get the pressure offloading that they need for whatever reason, then it's only going to keep that wound going. Erin, would you like me to talk a bit about this picture?
Yes, please.
Okay, so this is an individual that we saw many years ago. She's very interesting in that she had three PhDs, 2 in religion, theology, and 1 in pharmacology. And for whatever reason, she had started to self-inject. We were never really clear about why this started, but what she was doing was taking the pill and boiling it down and scooping off. Some of these wounds are caused by gravel, some of these wounds are caused by injecting codeine. And she came to us because people didn't know what to do with her. And interestingly enough, the physician that I work with one day was sitting in another room, and this person said to me, well, I guess I should stop injecting my Gravol. And he hollered from the other room, yes, you should. And her comment to me was, somebody is listening to me. Maybe you guys know what you're doing. This person has unfortunately passed, but these wounds did go on to heal. And part of that, or a good part of that, was the fact that we had built a very trusting relationship with her, and that we listened to her, and we didn't label her crazy as most of her previous care providers had, and we didn't give up on her. And she was the most delightful individual that I have met in my career. So even the other piece was we couldn't figure out why these wounds weren't closing, and we did an X-ray, and we quit counting after we counted 50 broken off needles in the wound. So we had an idea of what was going on, and we just kept working with her. Some of those broken off needles did work their way to the top, and we did remove them. But she did pass from this earth, as far as we know, with no wounds on her legs or her arms.
And I think this is kind of interesting because these were subcutaneous injections. So this is kind of an example of wounds related to like skin popping, as we would call it, kind of in our harm reduction community.
Yeah, and I know from working with Erin that developing that relationship is so very, very important. So. And then we have the non-healable wounds. So these are wounds that do not have adequate blood supply to support healing, and you can't correct it. Or you have something like this, the picture on your right as you're looking at it, that is a breast cancer that has metastasized. So these wounds are not going to heal. So what you're trying to do here is make the person as comfortable as you possibly can with good pain control, and to keep the bacteria as under control as you possibly can at this point. So those are the three pieces that we look at.
Was I going to speak to this one, or you?
I think you were.
Okay. And we wanted to talk about as well documentation, because I think it's so very important, and it's something that's very challenging actually with wound care, because you're trying to put into words something that's sort of ineffable. So I think it's really important to look at, like, what is your organization's wound care documentation tool? Do you have one? Do you have a shared language for describing wounds and monitoring progress? And, you know, describing things such as size, exudate borders, depth, tunneling, undermining plan of care. And I think I work also at the wound care clinic at Women's College Hospital, and the practice that they use increasingly is actually like photographs of the wounds to monitor progress, because really, like, as much as you can describe something with words, like, that picture is really going to show you what's actually going on and how things have progressed or decompensated. But whatever you're doing, that consistency is key. And I think that's something that's really challenging if, you know, when care is fragmented, which often it is for the folks that we work with, maybe receiving care in various different places, and hospital emergency room or various different kind of settings, having that consistency can be really challenging. So I think it's something that's good for us to think about in our practice. Do you have anything to add?
It's interesting. I spent Saturday afternoon on a call, on a focus group call, and we were asked to organize in priority what we thought was important for possible research in the future. And one of the top 10 was getting being consistent in how you document a wound so that everybody knows what you're talking about. And, you know, it's also very interesting how engaged the person with the wound can be. If you keep them in the loop of what you're talking about, and if you actually tell them the measurement that you get, very often they will be able to remember what the size was, or say, no, that's kind of not what they got the last time. So engaging the individual in the care and in the documentation is really helpful. So just as an aside there, and then for that one. So I was talking about the wound bed preparation paradigm, and this was just released in 2021. It is open access on Advances in Skin and Wound Care if anyone wants to access the whole article. They've come up with 10 statements for addressing a chronic wound. And as you can see, they start with the person with the chronic wound. Important to identify what that cause is. And it's also important to talk about the patient and the family or center of care concerns. Erin, did you want to add anything about that?
Yeah, I think in the harm reduction community, the patient and family-centered concerns, I think sometimes the general medical world sees folks who use drugs or folks who are houseless as without family. But in fact, like, we know that people have really rich communities of support. And so identifying who those people are, who those support people are, who can help people with their dressing changes or with, you know, making it to appointments, all of that kind of stuff. I think we know in this community that's those folks are really important and need to be engaged in care as well. Yeah.
Culture is also important. You really do need to understand where that person with the wound is coming from, and what their culture and what they perceive as being helpful to them. And sometimes the medical community has difficulty accepting or being okay with some of the more natural treatments that are out there. And again, it's the listening and finding out where that patient and that support, the person, I should say, and that support system is coming from, and then trying to work with them. But the next step in this paradigm is looking at how healable is that wound. And we've already talked about what a healable maintenance, non-healing, non-healable wound is. And there's also that palliative wound. And then what to do for the local wound care. So the three areas to look at are debridement. Can that gunge that's on that wound be eliminated? Is that area inflamed, or does it have local or deeper infection? And is the moisture within the wound balanced, so that it's a little bit like the Three Bears story, where something isn't too hot or too cold. It needs to be just right, that moisture, in order to allow the body to heal that wound. And then if these things aren't moving, the debridement, the inflammation, the moisture balance being corrected, isn't moving the wound forward, then there are other modalities that can be used to help that. And by looking at whether the edge of the wound is closing in or not, you would decide whether to use those modalities that may or may not be available in the community. Next. Erin, any other comments?
No, I think I'm ready to move into our case study.
Okay, take her away.
So this is my case study number 1. And I would love to just see what people think, like throw it in the chat. What are we seeing? What is this that's going on?
Are you talking about the leg or about the butt?
Both.
Okay.
This is the same person. Is there anything coming up in the chat? I don't seem to have the chat on my
No.
screen anymore.
No one wants to take a stab at this.
Nothing in the chat yet, but we've got our eye on it.
Okay, so let me tell
Can
you a
make
little.
it full screen? Someone asks.
Oh, you're put it in presentation mode.
Oh,
Erin.
sorry. Current slide. Yeah,
There you go.
my apologies. So let me tell you a little bit about this woman. She's very dear to me. I've known her since 2017 was when I first met her. And actually when I first met her, she was like just an active woman. She's in her early mid 50s now. She takes care of a lot of people on the street, and just has like a really rich network of people that she looks out for, and they look out for her. Anyways, she's very beloved. And in 2018, 2019, we know like she would come access the site every day, and then we noticed that she wasn't there, and so we started looking for her like you do, and at that time I did not have access to Connecting Ontario, or we didn't at my site, so we were just calling around, and finally we were able to find her. She was actually in ICU at a hospital, and she had been admitted for like surgical evacuation of a spinal abscess. So this woman, and FYI, she in her younger days was a professional dancer. She danced in like music videos and different kinds of settings, and as a result of this abscess in the surgery, she has been wheelchair bound since. So she's able to weight bear a little bit, enough to transfer, but has not regained the ability to ambulate. So this has been a very long journey with these wounds. I think obviously the wound on the right, it's a pressure injury. And that has been there since 2019 when she was in the hospital recovering from the spinal infection. So this was a wound that started while she was in hospital, and has gone through various phases, but actually what we're looking at is it's in a pretty good space. She has done a lot of work to keep her wounds clean and dry, even though it's pretty challenging, but she's been very diligent with it. So she has had this pressure injury and also pressure injuries to her ischial tuberosities on both sides, one of which is reopened, and you might be able to see just sort of the edge of the dressing on the left hip there. So that one has reopened. And then the leg, she had been admitted recently to hospital with COVID, and when she came out, she had this new injury on her leg. And I'm wondering, does anyone have any thoughts about maybe some of the reasons why this pressure injury is having a hard time closing? It's much better than it was, but why it's taking so long to close? Anyone in the chat? No, nothing?
Not yet. Oh, does she smoke? Katie asks.
Oh, she does a little bit. Yeah.
And Bernadette suggests difficulty with relieving pressure. Carrie wonders blood flow, poor circulation, pressure from a wheelchair.
Yeah,
Casey adds.
you all are brilliant, all of these things.
Nutrition, Lori wonders.
Yeah. All of these things, all of these things. I think the picture on the right, I like it because you can sort of see her her wheelchair to the left there. And yes, that is not optimal seating. Unfortunately, there are a lot of barriers for people to, I mean, it's hard enough to get a proper wheelchair. And then once you have it, to try to get maintenance on it, to, I mean, she's sitting on the bag. Underneath it is a Roho cushion, but the Roho cushion is just completely deflated. So having that, like, the system be responsive to people's offloading devices and mobility devices is really challenging. And actually this wheelchair is not the one that was fitted for her, because at one point she'd had to go to emerge, her wheelchair got left behind, it was lost. So she was in another wheelchair that was not properly fitted for her. So the offloading is a huge thing for this particular wound. It's really difficult for her to offload. And then for a long time, she was unhoused. So she was in the wheelchair 24/7. She, as of the past year or so, has had housing. So she can offload, she can lie on a bed, and her this pressure injury has gotten a lot better as a result of that ability to offload. And then the leg, I think, yes, is probably an injury from this wheelchair that was not fitted for her, and kind of presents its own hazards because it's not the appropriate fit for her. So this is really, again, like a system issue. If you can't offload a wound that's related to pressure, it's not going to close. So, I mean, the fact that it looks as good as it does is a total testament to her diligence with doing regular wound care and keeping as dry as she can and all of those things. But yeah, without that proper seating, we're looking at kind of a maintenance wound for now.
The wound on her leg almost looks like it might have been a hemorrhagic blister from some kind of a trauma when we were looking at this. I hadn't looked at it the way before, but I like the comment about it looks like a butterfly tattoo, because it does. When you actually look at it more closely, an unintended butterfly tattoo, but it does look like it was a hemorrhagic blister that is drying up. And this person has faced these challenges, but I must say that this seems to be something that everyone that is in this situation faces to a certain extent. Because people in our community of practice have trouble getting maintenance on their wheelchairs and their beds and whatever else they're sitting on. They put in a request and 6 weeks later, nothing's happened. So this is a true systems problem that goes across everything. And I don't know what the answer to the situation is. But it is costing everybody, not only financially, but in quality of life. So it's something that we all need to work towards to try and get this resolved.
Yeah, and I think part of the challenge here was that, and I think everyone on this meeting will understand, like, there's so much turnover of care providers, especially right now. So she had a really great sort of case coordinator, And then he left his position. So she was kind of in between case coordinators, and it takes time to get caught up on everybody's, paperwork and where they're at with everything. So I think that was a system factor that contributed to this. And I also think that the point about nutrition is huge. A lot of folks that we work with don't have food security. So she does have, a prescription for Ensure, and I guess that's okay, but it's not the same as having 3 square meals a day. So I think a lot of the folks that we work with are kind of battling against that factor when it comes to wound healing, is that it's just not the adequate nutrition.
And just a tip that just came to mind that we have seen, and that is something fairly easy to correct, is if people have ROHO cushions, be they inflated or deflated, just have a look at the chair to make sure that the ROHO cushion is right side up. We have had people come in with the ROHO cushions being upside down, and that only adds to more pressure. The other piece of, the other tip is that if you can have the least possible amount of stuff interfacing between the ROHO and the individual, the better the ROHO works, even if it isn't totally inflated. So by putting something to protect the ROHO, and I understand why people do this, but if you put something over the ROHO, then you're decreasing the effect of the ROHO. But I know why people do this, and just as a point of interest and information for everybody.
Yeah, and that's true for any offloading device. Yeah. Any layers in between are going to be increasing the pressure.
Yeah. Any other comments about this? I think this woman is doing a phenomenal job with what. Oh, I want to know what the diagnosis was on her leg from hospital, Erin.
Sorry, Pat, just before you say that, can you explain what a ROHO device is?
Oh, okay. Erin, you want to go or you want me to go?
Yeah, so a ROHO is like a seating device. It's kind of like a cushion that you would put on the seat of a wheelchair. And it has sort of like individual pockets that are inflated, to not too firm, not too soft. They kind of have to be just right, again, to help offload pressure from sitting.
It looks popping paper, the bubbles on popping paper. So it's obviously the bubbles are bigger, but it looks like black, and it feels like a rubber. I don't think it is. I don't know what it's made of, but they're about 10 centimeters high, and there's a valve that you can inflate air into, and some of them are divided into 4 sections so that you can inflate and deflate each of the sections, and others are all one component. And yeah, but just as a visual, an oversized piece of popping paper, so that it can even out the pressures.
Yeah, and basically the point is you're trying to have less pressure on the area where there is an open wound, or to any areas that might be at risk for skin breakdown.
Does that help, Rebecca?
I've just popped a link in the chat as well with the
Hi, this is Lisa Gillespie calling from Southwestern Public Health.
Hi.
How are you?
Good, thanks. How are you?
Good. Is this Diane?
No.
Okay, sorry.
Okay.
I thought Lisa was asking you a question.
I did
Here we
too.
go. Okay, go ahead.
It was the wrong number. Okay. So I think I'm going to move on to the next case study. So I apologize for the quality of this picture, but we are looking at a foot. So kind of at the bottom of the picture is the heel, and then the foot is, the toes are kind of not in the picture, but at the top of the picture. So this was a gentleman in his 30s who had this wound on his ankle for over a year, and it just was not closing. It would like almost close, but then it would open up again. And at one point he had it surgically debrided because it had gotten quite infected. But something that he had just struggled with for a couple of years of opening and closing and opening and closing. And again, when I was working with him, I did not have access to Connecting Ontario. So I had to put like my detective hat on and try to figure out what was going on. He shared with me that he had been in a motor vehicle accident like 6 years prior and had had extensive surgery to that right leg. So that kind of made me think. I was like, oh, there's surgical hardware in this foot. That kind of got me thinking that like maybe the reason why this wound is having such a hard time healing, because otherwise he didn't really have a lot of risk factors, healthy young guy, not a lot of like underlying chronic health conditions, but he was having this wound just kind of like improve and decompensate. So I sort of started to wonder about osteomyelitis. And in fact, when it was open, there was like quite deep tunneling. And when we removed some of the scar, just some like gentle debridement of the dead tissue, we could actually see that there was tunneling quite deep and purulent stuff coming out of it. And I wonder if folks can see here at all, or can tell from this picture, but the wound bed is also kind of hypergranulated. So it was, Pat, can you define hypergranulation in a succinct way?
It's an overgrowth of granulation tissues so that when you're actually looking at it, you can see the tissue above the edge of the wound.
Thank you. So, and it was kind of boggy granulation tissue. And I was kind of wondering what to do with this wound. And I sort of thought, well, you know, he's kind of swollen. There's still some purulent stuff, even though the wound was generally getting better with local wound care. And then I consulted with Pat and she said, yeah, I mean, hypergranulation tissue can definitely be a sign that there's active osteomyelitis. Even though that isn't necessarily apparent from this picture, right? Otherwise. And so this is one situation in which compression worked wonders. So he was on kind of like, he had been on antibiotic therapy, just sort of like indeterminate length, just ongoing BID, I think amoxiclav, that he was kind of like intermittently taking, intermittently having prescribed, and for his particular osteomyelitis, which I found out later had been diagnosed previously, was just sort of, you know, not sure how long that therapy was going to be. It could just be, you know, ongoing for months. But I suggested to him, I'm like, would you consider compression? Thinking like people hate compression and there's no way that he's going to wear it. I don't even wear my compression.
Erin, are you talking about compression socks or compression wrap?
I was well, I have access to Tubi Grip and, you know, feel comfortable applying that myself. So I asked him if he would be interested in having that applied. And he was like, yeah, I'll try it out. And he actually loved it and was very diligent about wearing it. And actually that one thing that we did seemed to really improve the closure of this wound, as well as trying to find out who was the last person who prescribed his amoxiclav, connecting with them, and getting a renewal of that script, and then actually supporting him with the med adherence by keeping the meds at our site and giving him reminders, engaging his partner, who was very effective at reminding him and getting him to take his antibiotics. So those were the pieces that we did. And that was it. Pretty well closed, that initial wound, but as you can see, there's still some active infection going on, as there was still some purulent drainage happening from satellite sites. So in this case, we really needed to get a consult, get him connected back with tertiary care. We'd kind of, between the two of us and between the three of us and between the whole community that was working on it, sort of did what we could in community, but ultimately really needed to think about removing some of that hardware to really actually deal with treating the cause. So I thought that was an interesting case study. And I don't know if other folks, I think we do see a lot of osteomyelitis in our community. And I think there's a lot of interesting implications for antimicrobial therapy as well.
And I think the important piece around this, if things are not progressing, you have to keep reassessing and asking yourself, what isn't going right here? What else do I need to do? And I know with this particular gentleman, Erin and I had a few conversations back and forth about what is happening, and then trying to access the appropriate care. Because if it's an osteomyelitis and requires intravenous antibiotics or requires a change in antibiotics, it is something that needs to be considered, and it needs to, probably an infectious disease person is the best help that you can get. And removing that hardware is the only thing that's really going to fix this problem. But can you remove that hardware is the other question. You might not be able to remove the hardware. You may just need to deal with the chronic osteo. And I know that we're all we're trying to be cautious about the amount of antibiotic that we use, but some instances people need to be on it prophylactically. So.
Pat and Erin, there's two questions in the chat here. The first is from Mary asking, would it indicate tunneling was still occurring if it had a satellite? That's language I don't understand.
And then satellite spot where you said it came out at another area.
I don't know that there was specifically tunneling from that spot, or if the infection was finding another way out. It never tunneled to that particular spot when I probed, but I mean, who knows, right? Because an osteo is quite deep. Yeah, it's a good question.
And as with everything, if there's a buildup of anything, it will find its way out. So if it's like a foreign body, like the person that I was talking to you about earlier with the broken off needles, they'll work their way to the top. This fluid may be going along the plane of the muscles and the ligaments that are in there. So it's following, and that particular area was just a little bit weaker area in the skin where it broke through. So Rebecca, interesting that you talk about language, and that's one of the things that we all need to be consistent about, because we throw out terms that we think everybody should know, and it's totally chronic wound care language. It's not necessarily something. So thank you for saying you're not quite sure what's going on, because we would.
Well,
I'm
I'm not a clinician. And this is for clinicians. So I assume you all sort of understand, but I guess even within. There's another question from Bernadette. Bernadette, do you want to ask that yourself?
Sure, I'll unmute for this. So, Erin, I was just wondering if you wanted to comment on the difficulty that folks have with accessing IV antibiotics when they're known to also inject drugs. So, the reluctance for people to put in PICC lines,
Mhm.
difficult venous access, length of course in hospital, and any suggestions you have on supporting folks and making that more successful.
Yeah, I think people face so many barriers to receiving IV antibiotics, or having a PICC line put in for like community antibiotic management, because of the stigma against people who use intravenous drugs, obviously, right? I think we all know that. So some people aren't even considered candidates for having an IV or having a PICC put in, because folks are, I guess, concerned that people will use the PICC. And the reality is, some people do use their PICCs also for administering other drugs. And I think we just need to be real about the fact that we need to just apply harm reduction approach to that as well. Like, there are ways that people can maintain a PICC, get their antibiotics, get their needs met. Harm reduction, obviously. Because yeah, I mean, I think this particular person had been on BID dosing of amoxiclav for a really long time, and I'm not sure that it was ever even considered that maybe they would switch it up, do IV antibiotics. I wasn't sort of, privy to the whole history of this wound, but yeah, for sure, like he was on oral antibiotics for a really long time. And as far as I could tell, it had not been considered for IV antibiotic management. I think it helps when we're able to support people in going to appointments. I think clinicians in tertiary care make different decisions when they are being watched. And so that's been, I think, a big thing for me, a big learning thing for me, is that it's not only important for me to make the appointment, but sometimes important for me to go to the appointment. Because I do think people make different decisions when they know that there's a community watching. Yeah, I don't know if you have anything to add, Bernadette. Obviously, you have lots of experience with this.
I don't have anything to add to obviously your brilliance in this, Erin. I think it's just like one of those things that we continue to butt up again, and it's against, and it's kind of this continual education piece that has to happen with individuals when they're doing a risk assessment, and really focusing on the individual. Like, we know that people inject drugs, we know that people are going to use drugs, but weighing that against like somebody's untreated osteomyelitis and the real implications of that, I think that it's problematic when those risk assessments are done and the provider is the center of that risk calculation as opposed to the client.
That's exactly it. I think we talk about risk assessment and we don't always talk about whose risk we're trying to mitigate. Yeah, absolutely. And I think we've all seen people who inject drugs like have really successful experiences with having a PICC line and getting their antibiotics and doing whatever else they're doing with the PICC line, but getting those antibiotics and completing treatments.
It also, some of the oral drugs will help osteo as well as IV. I'm a nurse, I can't prescribe, but I know in our clinic, something like clindamycin is felt to penetrate just orally, just as well as it does intravenously. So it's the prescriber and knowing what will work for the individual. The other way, if one is really concerned, I think that providers need to consider is using intramuscular injections of antibiotics as well. They will work as effectively. So you don't only have to go with intravenous. There are other ways of approaching the issue. So I think providers need to be better educated, and I think this group is trying to do that out there. So, but you need to keep in mind that there are other ways of administering antibiotics that work just as well as I do.
Yeah, I think the kind of newer research is showing that penetration with oral can be as good for certain osteomyelitis as well. But yeah, still absolutely take Bernadette's point. There's lots of different kinds of conditions that, you know, do require IV antibiotics, and that doesn't always happen for the folks that we work with. Yeah. But that does lead us nicely into the next slide, which is to talk a little bit more about infection. And I'm sure people are interested in that topic. Yeah, so can I speak to this one a little bit before you give a more fulsome?
Go ahead, be my guest.
Okay, so the nerds and stonies, it's a really dorky, I don't know what the term is, but it's a mnemonic.
Yes.
It's a very dorky mnemonic, but it kind of like blew my mind when I was first introduced to it. And I think is really helpful because when we see wounds in community, I think we often sort of, we see inflammation and we think this person needs they need antibiotics, right? And especially like if you're seeing someone where you don't know their health history or you kind of don't have a lot of context for what's going on, that's seeing that inflammation can cause some panic. So this particular mnemonic or tool has helped me to think about if what I'm seeing is sort of a superficial infection or inflammation, or whether it's like a deeper infection that requires systemic treatment. So I think obviously the last case study is somebody who needed to be treated systemically. That was an osteomyelitis. There was bone involvement. But you know, sometimes you can treat topically, like that inflammation that you're seeing is superficial infection. So Pat, do you want to explain nerds and stonies a little bit more?
This was the brainchild of the physician that I work with, and it is also, if you Google the resource, and we've got a list of resources at the end, but looking at pain and wound infection with Sibbald, Wu, Aiello in 2006, and then Wu and Sibbald in 2009. When Dr. Sibbald talks, he talks about a wound being like a soup bowl. And the deeper into the bottom of the soup you go, the more you find debris. So at the top of the soup is where he came up with the superficial bacteria. I should start off by saying all chronic wounds have bacteria in them. And it depends on how long they're present, how many types of bacteria they have. And we have a slide to show that a little later. But when you're looking at very superficial kind of infection, you will find that the wounds are not closing as you would hope they would be. And with chronic wounds, studies have shown that if a wound is on a healing trajectory, it should actually be smaller at 30% smaller at 4 weeks. If you have superficial infection, your exudate will be increased, and it can be serous, or it can be bloody, or it can be pussy, but there will be more exudate. And then Erin talked earlier about the red friable bleeding tissue. So the friable, when you touch that tissue, it bleeds just with the lightest touch. The debris is the slough or the yellow material that's in the bottom of the wound, and there will be an odor that comes from that. If any of you are doing dressing changes, please do not check for odor until after you've cleaned the wound off with either potable water, sterile water, or saline. So if you have any three of those particular signs, you can treat that wound superficially. And there's a question in the chat about what types of wounds would you treat with silver Bactigra non-adherent dressings. These are the type of wounds that you would treat with those, with the antimicrobials. If that wound is, if the infection is deeper, then your wound gets bigger, your temperature will increase. It may or may not probe to bone. And in the last case study, Erin, could you feel the hardware when you were probing to that?
Not in the ankle, but higher up towards the knee where he also had hardware, and there was some purulent drainage
out of that, so that you can actually probe. Not all of us are fortunate enough to have the sterile steel probes. So using a sterile Q-tip and using the non-cotton end of it, you can use that as your probe. You'll see new areas of breakdown around that area, and the exudate will be increased. There will be redness and edema, and there will be odor if there's deeper infection, and that does require systemic treatment. Interestingly enough, Sue Gardner from England did a very small study, but in 100% of the people that she talked to that had infection in wounds, reported that there was increase in pain. So any one of those signs that you see can be replaced with the symptom of pain if you're looking at nerds and stonies. Kevin Wu, who is a nurse and a professor at Queen's University, actually, along with Dr. Sybil, validated the nerds and stonies criteria and found that by comparing it to swabbing and laboratory reporting of wounds, did show that there was increased in bacteria. There's a question here about, sorry, what do you mean by the O in stony? Os? It means it probes to bone, or you can feel something underneath there, or the bone is exposed in the area. I'm hoping that that's helpful. But if you can feel, like Erin said, she could feel the hardware, that means that there's a problem in there that needs to be addressed. Interestingly enough, when they were doing the validation study, they found by using an infrared thermometer that if the temperature was increased 3 to 5 degrees, that was 8 times more likely to be indicative of there being a deep infection there. If those of you who are dealing with chronic wounds in your practice want to watch for the infrared thermometers, I'm not promoting the company, but Canadian Tire will have these $99, $100 thermometers on for $20, $25, and they have been a real boon to people within the chronic wound care practice. The infrared thermometer, the original one, was brought out to, there's a medical grade one that is was brought out to look at skin temperatures, but you have to be within 2 centimeters of the skin in order to get a good reading, and they are between $800 and $1,200, depending on where you get them from. The ones that Canadian Tire and Princess Auto and the auto shop sell, they were originally designed to take temperatures of car engines and truck engines to look for heat leakage around windows, etc. But we have actually done a study that has validated that as well. So having that thermometer is really helpful. Erin, do you have one for your practice?
I do, yeah. And then just for anyone who doesn't know, you're comparing the temperature to the wound with the skin on the opposing limb, or sort of the same kind of anatomical area, but on the other side, to get those 2 readings. And then you're kind of looking for that 3 degree difference to indicate that there is a deeper infection.
Yeah.
because sometimes just touching the skin around the wound isn't going to give you an accurate gauge of how hot it is.
Yeah, and if someone has just come, if you've just come in and your hands are cold and you touch, you're going to get a different sense than if you've been inside for a while and your hands are warmer and you touch. So using this infrared thermometer has proven to be a boon in the toolkit. But it's only a part of the puzzle because infections are clinically diagnosed. So it's your clinical expertise that helps you to determine whether that wound is infected or not. And so using this mnemonic or this tool will help you to remember what the things are that you should be looking for.
Do we want to move on? Oh,
there's one more question in the chat there.
What is the best
way to treat? Exactly, you go for it. Yeah.
What is the best way to treat topically Fusidin antibiotic infused dressings? Okay, the physicians I work with are dermatologists. Fusidin is an excellent cream to treat with and readily available. However, because it has lanolin in it, it can be sensitizing. So people can have develop a contact dermatitis from the Fusidin. The antibiotic infused dressings, there are not a lot of them that are available. You can buy Band-Aids with them in, but the next dressing shows more, the next slide shows more about the antimicrobial dressings. So in chronic wound care, there are 6 categories of dressings you can see there. And what the companies have done is they've taken each of those categories and put an antimicrobial into that particular dressing. If you're working within the community and you're working within the home care situation and that person is getting those dressings, you need to know what's available in your community. The other thing you want to know is that some of the products are pro-inflammatory, so they increase the inflammatory response that you're getting, and some of them are anti-inflammatory. So if your wound has reverted back to that inflammatory phase, you want a dressing that's going to take it out of the inflammatory phase. So using the silver impregnated dressings or the honey impregnated dressings will get you out of that inflammatory phase. If you've got a wound that's stalled and not going anywhere, you want to get it back into the inflammatory phase so it can get on with it through that diagram that I showed you. You want to use something like povidone iodine, so betadine, iodosorb, inidine kind of thing. The PHMB, the polyhexamethylene biguanide, and the methylene blue crystal violet, those dressings attack the bacteria within the dressing itself. So the bacteria goes up into the dressing properties dismember the bacteria and hold on to it within the dressing. It sounds a little complicated and a little confusing, but that's basically how they work. So it depends on what you have available and what your assessment of that wound tells you what the dressing is that you should be using.
mm-hmm. And I think probably the most common thing that people have access to in their practices, the iodine impregnated gauze or the paste, or the chlorhexidine impregnated gauze, or ribbon gauze. And I think, the iodine impregnated stuff, it is pro-inflammatory. So it will help unstall a wound and also break down, it'll penetrate into biofilm better. But if you have a wound that's really, really tender and already like in an inflammatory state, then you might want to choose, you know, the chlorhexidine. Or if you have the funds to be purchasing silver dressings, you could use that as well. But just to keep in mind that any silver dressing is going to require moisture to activate the silver. So you have to have some kind of exudate happening with the wound.
The question is, what is PHMB? It's polyhexamethylene biguanide, and it is related to chlorhexidine. So it has an extra molecule attached to it, to the chlorhexidine. So chlorhexidine, trade name is Bactigraph, which people are most familiar with, I think.
Mm-hmm.
So it's a good, but you know, interestingly enough, Erin wrote an article, if you don't mind me sharing this, Erin, wrote an article, and one of the reviewers came back to her with, why did she use povidone iodine or betadine? And the answer to the question is that's all she had. And the reviewer didn't say another thing. So you need to use what you have available. The other thing is, if you know that a wound isn't going to heal because of the circumstances, using something like the povidone iodine or betadine, as it's commercially known, will help to keep the bacteria under control and will help to decrease to some extent the chance of infection occurring. And that's what you want to do. In a lot of these instances, you can have all these fancy dressings, but if the wounds get infected, then you have to move on to more expensive modalities.
Mm-hmm. Yeah, I think, you know, there's so many dressing products on the market. A lot of them are cost prohibitive. And I think in my practice, I try to keep it simple, understanding that we're probably going to have to do more regular dressing changes because people are unhoused and they're it's hard to keep the dressings like clean and dry, so we're just going to have to be changing it more. So as long as we're meeting the needs for, you know, bacterial management, moisture balance, then I think, you know, keeping it simple is generally the way that I go. And I think I just really like this picture because this person did have a calcium alginate, and I think it probably had some antimicrobial property to the calcium alginate, but then it was covered with an occlusive dressing. So we did not meet the needs for moisture management in this wound. So thinking about how you're using your products together as well is really important. Because it might be, you know, the calcium alginate is drawing stuff out, but then you're trapping it under this film dressing, and it's sort of just kind of counterproductive there.
I would think that within your practice settings, if you could have one other product other than your povidone iodine, a calcium alginate would be a product of choice. Not only does it help absorb moisture, but it also helps to cause hemostasis because of the way it acts when the sodium from the blood interacts with the calcium in the dressing. It has the hemostatic property. And calcium alginate is actually made from seaweed. So it's very helpful. Erin, do you have access to that in your practice?
Yeah, we do carry some.
Yeah, and so it's one of the more valuable ones. But yeah, I would think when you took that off, the odor from that would be pungent.
It was strong, yeah. But of course, like there are absorbent dressings. Some of them are also quite expensive, but you know, a Mesorb or a Mextra is a great option if you're really needing to manage some exudate. And I don't know, maybe I could have thrown one of those on top of this just for the first dressing after the IND that happened here for the abscess. But this also makes me think about packing, ribbon gauze. And I know there's lots of conversation and debate about that, about what ribbon gauze do you use? When do you use it? Do you soak it in saline? Do you soak it in iodine? What do you do? And I think it depends. It depends on what the wound needs. And often people will come away from an IND with packing put in. So at your first dressing change after the IND, you'll have to decide whether packing is still appropriate. But I would say that there are options for putting in the ribbon dry. There's chlorhexidine impregnated ribbon gauze that can be quite good for that if you're trying to wick fluid out of something, which would be true in this case. And also, I don't know who, I think Heather Orson was the first person. No, was it you?
No, it was
stuff?
actually, yeah, it was myself and a summer student.
Oh, I'm sorry.
That's okay.
Pat said it. With packing a wound, fluff, don't stuff, because if you're packing it too tightly, you're actually gonna be irritating the walls of that wound and causing more inflammation. So sometimes, we have to be thoughtful about how we're packing and when we're packing a wound, because you don't want to actually cause trauma to that tunnel in our efforts to really get in there.
Yeah, if you pulled packing out and it's doesn't have a lot of bloody residue on it, and then you pack the wound and you pull the packing out and there's a lot of bloody residue, you have to ask yourself, are you irritating that area when you're doing the packing? Because sometimes when you're putting that probe in to put the packing in, you're irritating the tissue that's trying to heal itself. And when you have a fresh surgical wound, you may pack that wound fairly snugly. But when you're trying to, if you've had an incision and drainage done, you want that fluid to come out. So what your packing is doing is acting like a guide for the fluid to come out onto the dressing that's going to absorb it. You don't want it trapped underneath that packing. So packing it lightly works much better. In the interest of time, I think we should probably move on, Erin.
Yeah.
Talk a lot. I was talking earlier about what bacteria is present when you've had chronic wounds. So if a wound has an infection and is less than a month old, and the person is not immune compromised, then you're probably going to be treating for gram-positive or what the culture results are. And there was a question in the chat about, do you ever, is it helpful to swab a wound for culture? And it's helpful to swab wounds to get what the sensitivities are, so you know which antibiotics to use. The important thing before you do a swab is that you cleanse the wound. We had a microbiologist speak to us, and after an hour's lecture, his takeaway message was, before you do a swab, clean off the wound. You don't want to swab the gunge, because there's gunge there. You already, if it's slough or necrotic tissue, you already know that there's some bacteria there. What you want to do is cleanse the wound and then take a swab of the cleanest part of the wound to send it for your culture and sensitivity. So it is helpful to swab if you're looking to find out what the best antibiotic is to use. Going on with this slide, if the infection is greater than a month old and the person is immune compromised, you're probably going to have to treat both gram-negatives, gram-positives, and anaerobes, so a much broader spectrum. And people who you are dealing with are compromised, are immune compromised, because they may have problems with food, they may have housing issues. They don't have to have a comorbidity to make them immune compromised. So if you are a prescriber, you keep that in mind when you are prescribing.
And I think there's a lot of, client-related factors as well. This is a journey where I've been learning, like also considering like the frequency that someone has to take the antibiotic. How easy is that going to be for someone if they don't have like a secure place to keep their antibiotics, or if they're in shelter and they have to be out of the shelter during the day? Are they going to be able to take the antibiotic with like the frequency that it's prescribed? And also things like doxycycline is a great antibiotic to decrease inflammation. But as I found out, working with a gentleman who had an osteomyelitis of the thumb, and he was prescribed doxycycline, it actually made him quite sick because he was living in an encampment at the time, and it was the summer. So he was constantly being sun exposed, and exposure to the sun when you're on doxycycline can make people feel really crappy. So also taking into account those other pieces. I mean, I'm not a prescriber, but when folks are prescribing antibiotics, around those kind of factors that can have a really big impact on whether someone's able to take the course of treatment.
And the other thing is, how often do they have to take it? It's far easier to take something once a day than it is 4 times a day. And that's in everybody's world. Mm-hmm. But it's one of the things that should be considered. There are.
Here's just a nice picture of a classic cellulitis that I'm sure everyone's seen in their practice.
And for those of you who aren't clinicians, the person isn't drawing on themselves. The clinician actually drew.
Yep, that was me.
Right?
Yeah.
It's
helpful
it's
helpful to mark the progress of the erythema.
Yeah. It's a very simple way for anybody to see what's happening with the erythema and if they need to take action or if things are resolving.
So we've included some tools and resources here if you're looking to do some more learning or reading. And I have to give a big shout out to Wounds Canada, and also just mention that they do translate their resources, so they're in English and in French. But they have a lot of really good tools and educational things that are relevant to wound care.
And they're free.
And they're free.
And they're free.
And a past president of Wounds Canada, so all of those things. Also just wanted to acknowledge the, I think the wound guide that was done by Dunn and Tim Gauthier in Vancouver. Yes, it's a really good resource and it's a good overview of the common kinds of things we see with people who inject drugs. So I think you all have access to that, and it was sent around. And also just to like, this kind of community of practice stuff is so important. Benefiting from our common wisdom and knowledge about wounds is really important. So talking to each other like we are today is a really, really important thing. So just to close off, we all know not all wounds in people who use drugs are a result of injecting. I don't think, I think that's, we know that there's lots of other things that contribute to skin and wound health for the people we're working with. And we need to really think about plans of care that reflect the person's goals, their living environments, and the resources that are available to us. And if you take one thing away from this, I think it's that, you got to treat the cause, you got to treat the system. And as an SOS community of practice, you are treating the system. That is what you're doing. And so you have those skills and you're doing it, but it's so hugely important. and yeah, the communication and collaboration with the person you're working with the person with the wound, and with all of their supports. Big thank you for joining us today. Thanks, Pat. It was fun presenting with you. I always learn so much from you, and I'm very grateful for that. And I think we have do we have a few minutes for questions or comments, or please reach out to us. We love talking about wound care.
Let me just step in for 2 seconds. I just want to ask everyone to please do the feedback survey. There's only a couple of questions in there. And it's really helpful for our funders and reporting and stats and showing that what we're doing is useful to people. So really appreciate that. But there's also a question in there asking what other topics you'd like us to make available to you as in workshops and things like that. So that's really helpful for us. And huge thanks to Erin and Pat. And we're really looking forward also to offering a similar workshop on wound care for non-clinicians, acknowledging that a lot of people provide care to each other. So trying to make sure there's some good information out there. We also have some other topics coming up. I put them in the chat there. We've got a hot topic event at the end of February 24th, with Dr. Christy Sutherland, Leslie McBain, and Wendy Stevens. They're going to be doing a presentation on decriminalization. And then we have DOLF coming March 15th to talk about their work. And then at the end of March, we've got the SOS guidance document. The updates to that document will be presented to the community of practice. So questions for Pat and Erin, for those who are able to stay for a couple of more minutes. Oh, I also just want to give a big shout out to our transcribers, our translators, our French translators. Thank you so much for making it possible for us to offer this to Francophones as well. Thank you, Christine. Thank you, Emily. Questions for Pat or Erin? Lots of thanks to you both coming in our chats here. Thanks to each of you who attended here as well. Oh, Sabrina has a question. I was wondering if you could show us the big algorithm chart you showed us at the beginning. Pat, your complicated chart.
The wound chart, or the wound vet prep chart? That one? Is that the one you want?
I think that's the one they're referring to. Yes.
The complicated
Yes.
one?
The complicated one. If you can figure that one out, more power to you. There are so many factors that go on within the body to make that wound heal. And I think we need to recognize that our bodies are magnificent machines, and they fix themselves very, very well.
It is amazing.
Mm.
Erin and Pat, you sent some slides to us last week. Did you make significant changes to the slides? Or should we post?
I think so, but I could take another quick look.
Or do you want to just send me the ones you've got right there, and then we know it's the latest, and then we can share those as well, if you're comfortable with us sharing your slides.
Pat?
Yeah, I'm fine, as long as if you send it PDF, then everyone is given the acknowledgement that they should be for the slides, because there's wound care really needs to be community and teamwork, and it behooves all of us to go out into the community and find people. I know when we first started there, a nurse actually talked Dr. Sibbald into getting involved in wound care, and there was he and I trying to do wound care, and over the years we have developed a a large informal team of people that will help us. So we know people we can call when we get into a situation where we need their expertise. They may not always be there, but developing that support network is so important. And what you're doing here with your community practice is just so great. You're a real example of how things should be. So thank you for doing this.
Thank you. It is really exciting to see all the great work that people are doing and being able to have a place for us all to come together and share that work and learn from each other. We do have a question about whether or not this recording will be available for others to see. We had a lot of people who were like, oh, I can't be there today. Will I be able to see it? Yes, we'll get it sorted today, and it will likely have it up by tomorrow on our website under, I think right now it's under resources and then past events. I think it's still there as opposed to under events. Yeah, under resources. So that's where you can go, and we'll have the recording and some other resources that have been brought up today. Some of the articles and such that were shared in the guidance documents. So we'll post that all there. Jody's got a question for you. Do you have a particular resource for dressings?
If you want to know about the categories of dressings, Wounds Canada have what they call a product picker, and it talks about the different categories of dressings and what tissue type they're best used for and when to use them. If you're talking about actually physically getting dressings, the answer is no. Most of the people that we would see would get their supplies from home and community care. Mm-hmm. Again, going on the Wounds Canada website, you will find a lot of information about cleansing solutions and what to use, the different categories of dressings and how to use them. There are a number of different, what they call product pickers that are available. So, yeah.
And I would also plug that, I mean, we're not in like a, conferences aren't in person, but if they ever are again, going to conferences and visiting the different booths for the different companies with their dressings, you can often hook yourself up with some free samples. They're pretty happy to do that.
Yeah, they're happy to get their product in wherever they can get their product in. Mm-hmm. And I know that some companies have provided different dressing materials on compassionate use as well. So everything is out there and available to try and give the best care that we can.
Great. Okay, I think we'll leave it there. Thank you so much for being here today. We always welcome any feedback or ideas that you have. I'm really grateful to you, Pat. Really grateful to you, Erin, for putting this on for us today. It was one of the most commonly requested workshop that people were looking for. And we are hoping to offer a few more, and we're looking forward to having the workshop for the non-clinicians as well, because lots of people are interested in that. And yeah, big thanks to everyone. Thanks to the team for supporting putting this on, and to our translators.
Thank you for having us.
Thank you.